Whenever you're ready. Thank you. Okay. And then wanted to thank some of our partners in this really important work and sponsors. So wanted to thank our funding support from the Michael Smith Health Research VC, as well as our key partners in piloting and developing our toolkit with Interior Health. And specifically some of the clinicians that we have listed here. We want to give special thanks to for the work that they did in supporting um, and helping us develop this toolkit, which we'll be sharing about in just a second. I also just wanted to add that this is a little bit of a smaller group, and in our echo sessions, we try to like to have them a bit more conversational, but at the same time, we recognize that you are all maybe joining us on your lunch break. Might want to have your cameras off as you're eating or doing other things and whatnot, and that's totally fine. So we invite you to participate, jump in as you can, and engage with us in a conversation. And we'll also have opportunities for you to throw some things into the chat if your camera is turned off, and you don't want to have to unmute and whatnot. But just wanted to say that we really welcome sharing learnings. We're going to be sharing our learnings from what we learned, and we're curious to hear if they resonate or don't, or how not with you and your experiences in having these conversations in everyday practice. So that being said, just gonna jump into outlining our echo. In this session, we're going to go through, let's get the first bullet point, recent updates in serious illness conversation research, the current state of serious illness conversations, which we call SICs in BCs, and touching on those barriers and facilitators. We're going to talk about some implementation science and how we chose to integrate implementation science into our toolkit so people can have more earlier and better serious illness conversations in our province. And then just some opportunities to reflect on how are these conversations in my setting, and how are they working, and how might not they be working, and what opportunities might exist for better implementation. But maybe to start, I just want to start with a question, talking about what are serious illness conversations. And so I just wanted to see if you could use the thumbs up or raise hand icon, just hearing how many people are familiar with the term serious illness conversations and or have used them in practice, potentially in clinical practice. Okay, great. Seeing lots of thumbs up. So I'm not going to spend a ton of time going into depth, but just so we're kind of all on the same, I'll do some level setting here. Just going to put these up here. Perfect. Yeah, so serious illness conversations are conversations between a healthcare professional and people with a serious illness and their loved ones. And the intention of these conversations is, as the slide shows, kind of assessing an understanding of the person's health and what is likely to change in the future, understand what's most important to the person, coming up with a plan together. That includes that kind of talk about prognosis, potentially functional prognosis, and then finally to document and communicate that conversation with the rest of the care team. And ideally, this conversation should happen as soon as a person is diagnosed with a serious illness and occur at various points in their trajectory of the illness. And so one of the tools that was designed to support having serious illness conversations that has been picked up and that we've kind of adopted and promoted at the BC Centre for Palliative Care, as have many other organizations and clinicians, is the Serious Illness Conversation Guide. And so the Serious Illness Conversation Guide gives really kind of specific patient-tested language, as we know, to have these conversations and validated with people with lived experience.
Yeah, and now we're kind of curious about how your organization or your practice currently uses SICs. So there's a few questions we have. If you can leave your comments in the chat or feel free to unmute. But when you think about serious illness conversations in your work, how soon do they usually happen? Do they tend to happen early around the time of diagnosis or much later, closer to the end of life? So we have this scale here, and 0 meaning conversations begin near or at the time of diagnosis, and 10 for beginning at the final days of life. So if you can please enter your responses in the chat, that would be really great to see. So Corinne says 8. Mm-hmm.
Yeah, so leaning maybe more towards that last. Thanks, Alex. 6,
Mm-hmm.
5 to 7. Any others? Yeah. So maybe looking like it's in that 5 to 10 range here.
Mm-hmm.
And great, Cheryl, about first contact when they ask for service. That's interesting. Great to see.
Mm-hmm. Yeah, and seeing the range from 5 to 10, I think it is similar to what we've been seeing in our findings as well. Like sometimes, unfortunately, maybe it's not so feasible or with the health system context currently to start it as early as we want. So sometimes it falls a little bit later to that side. But that's also why we're hoping to use the toolkit that we'll talk about later to help people kind of start these conversations earlier as much as possible. Mhm. So the second kind of topic we want to think about is how serious illness conversations show up across a person's care journey. So in your organization, how often do these conversations usually happen? And for 0, it would be maybe they happen every time there's a change in the patient's condition or care. And then 10 would be these conversations don't really happen in the practice. So if you can share your responses, thank you. Mhm. Yeah, I see like a range of numbers, maybe from like, I see some from 5 to 10 and some 2, 3. Mhm. So there's kind of a variety of responses. Mhm. Yeah, thank you for all these responses. And the third kind of topic we want to talk about is the quality of conversations. So, when you reflect on the quality of these conversations in your setting, what comes to mind for you? And we understand that quality is quite subjective, and it can look different between different people or whether or not you have the capacity for certain things. But do you feel like you're able to have quality SICs in your setting or practice? And maybe some examples of some cues that speak to quality SICs are you're having a good chance to build rapport with the patient before having these questions posed to them. During the actual SIC, there's privacy. The patient can kind of determine the pace of the conversation. And following the SIC, there's time maybe to document and share that information across the team. So with 0 being high quality and 10 being lower quality, how would you rate your organization? I'm seeing a lot of like higher on the higher quality end, which is very good to see. Mm-hmm.
Yeah, and I like how Ellie points out that it also depends on the client's openness too, sometimes
Mm-hmm.
conversation.
That's very true. Yeah, thanks so much, everyone, for your answers and for getting some conversation going about what SICs look like in your setting. And so, in this presentation, we will talk about how we heard that many healthcare providers had knowledge around what a high quality SIC looks like, and they recognize the value of these conversations, but sometimes they still weren't having them in practice. And so, we asked organizations that had some success to share their strategies of how they made these SICs happen in practice. We did some research using implementation science methodologies, and we created a toolkit to support the sustainable integration of earlier, more, and better serious illness conversations into everyday practice and routine processes. And so, as Laura mentioned previously, while we know that the SICG is an evidence-based and validated tool, it was developed in Western healthcare settings. And so, just some recent updates in the research have also pointed to this fact. And as a result, the effectiveness of the tool can sometimes be varied in acceptability among diverse cultural groups. And it's been a pretty important topic of exploration, and it's come up in our research findings as well. I won't go into all the references here, but I do want to highlight that one of our partners in Richmond, who has done some past echoes with us at the center, has done some really great work on understanding cultural acceptability of the SIC among South Asian communities. So that's the second reference listed here. And in their work, they found that some of the key themes were death is sometimes viewed as taboo in some cultural contexts among South Asian communities. So, openly talking about death can be seen as disrespectful or inappropriate. And there's a much higher priority to preserve hope and harmony, especially among the family structure, and making sure everyone is kind of on the same page, but preserving that hope, that sense of hope. A second theme was that family centered decision making was really huge. And while Western approaches tend to focus on maybe individual autonomy and transparency at times, the South Asian approach that they found in this paper focused more on prioritizing relational autonomy, and decisions were made collectively with family in order to maintain family cohesion and to minimize distress among family members. And a third kind of theme that I wanted to highlight is Joshi. He found some generational differences in the way older adults and younger adults in South Asian communities view their relationship to healthcare providers. So the older generation preferred to have some sort of power differential between themselves and providers, or they were more accepting of that power differential because they viewed providers as people with authority whose role is to take the lead. So sometimes language that tried to position the patient with more autonomy didn't resonate as much. They would kind of ask, like, oh, why are you asking me this? Or shouldn't this be something you're taking charge of? Whereas with the younger organizations, or younger generations, they're a little more comfortable with being more active on guiding the decisions with the healthcare providers. And so these insights really highlight how cultural context shapes the way serious illness conversations are received and how they're practiced. And in our own work, we've heard a similar theme. And it's that while the guide itself is really strong, many feel they need more language and flexibility to adapt the tool to different settings. And we think, Joshi et al.'s work really illustrates the efforts of what this can look in practice, and we can learn how to better adapt the guide so it can resonate with diverse cultures.
Thanks, Grace. Yeah, and so kind of jumping off what Grace was just talking about adapting the language in the serious illness conversation guide, what we also are learning is that we also need to think about adapting our systems and workflows to incorporate serious illness conversations. And the reason why we want to think about workflows and systems in having serious illness conversations is to the point that Grace mentioned earlier, which is that we know clinicians value SICs when they have the training. They want to have them. They know what quality looks like. But yet that there's kind of this gap where they're not kind of still able to actualize them in practice. And so that's why we've really sought to understand clinicians' experiences of serious illness conversation around the implementation piece, beyond kind of the knowing and education, and going into how do we ensure that these conversations are happening more earlier and better. And so thanks for moving those little boxes along here. I'm just gonna fill that out for us. There we go. And so based on our research to date, we found that actions to improve the quality of SICs have really focused on education. And that's where previously a lot of our emphasis at the BC Centre for Palliative Care has lied in terms of thinking about serious illness conversations. And we do these we have these post-workshop surveys. And what we were finding from healthcare providers who had taken serious illness conversation workshops was that they felt confident, clinicians felt confident in in having an SIC and believed they were the right thing to do, but they weren't able to have them regularly in practice. And one of the main reasons that came up is clinicians felt like they didn't have enough time. And we had, as what we heard from them in those surveys. And so we wanted to dig deeper a little bit more into that barrier, because we think the barrier of not having enough time is pretty big, and there's kind of a lot of different potential barriers and facilitators within that piece. And so that's kind of what launched and started our work, was kind of thinking about the broader context in which people have serious illness conversations, thinking about the workflows and system pieces. And that's because the serious illness conversation is a guide, the SICG, as we mentioned earlier, but it's also a program that requires system level interventions and workflows. And when I say kind of system level and workflows, I'm thinking about how we need to be able to systematically and potentially consistently identify who has conversations, remind clinicians to have conversations, ensure the conversations are documented, and then shared within the healthcare team and then incorporated into health plans. And so it's kind of these broader workflow and system components that we're really thinking about it beyond that education and training. And I should also mention that when we think about the serious illness conversation program as a whole, which was also developed by Ariadne Labs initially, we can also think about mentorship and support. So beyond that one-time training, also how do we support newer clinicians, for example, in having conversations? They might have taken that one-time training, but for example, they might need a little bit more mentorship and support. And so that's an example of how the serious illness conversation program is meant to be a bit more wrap around as a process rather than just that guide itself, to ensure that those values and goals and understandings that were elicited in the conversation are integrated into the care plan and communicated across the care team.
Thanks, Laura. So, yes, to provide some more context and build on what Laura said about what data kind of has informed the work and helped us get to where we are to make the toolkit. When we were first looking at SIC training evaluation data, which we collected at 3 time points immediately after training workshops, 3 months after the workshops, and 1 year after, there was such a great uptake of the SIC education, but not many or not as many were implementing SICs in practice. So, like Laura said, we really wanted to understand why people maybe weren't using the conversations beyond the training. In fact, in our data, we found only about 50% of people who had been trained had had one serious illness conversation with the patient since the workshop. So this really drove us to look into the barriers and facilitators of SICP, the program implementation, using the various multiple research methods outlined on this slide. So we've spoken with key health authority leads in palliative care. We've had conducted a literature review. We interviewed some champions, healthcare providers who were regularly having these conversations, trying to understand maybe what helped them get these conversations out in practice. And we also surveyed and interviewed healthcare providers who had received training, but maybe were having trouble sustaining routine conversations in practice. And so based on some of these findings, I'll go through maybe a few of our key themes that represented some of the key barriers and facilitators that we found. And just want to preface that this is not an exhaustive list, but we are hoping to share a few that came up quite a bit. And we'd love to hear if any of these themes or quotes resonate with you. So in leadership and organizational prioritization, we found it does make a big difference for how clinicians felt, how visible and integrated the workflows and the processes that support SICs are in their setting. So the quotes here show on one hand, on the left, when leadership doesn't prioritize SICs, sometimes those requests in the workflow are structured in a way that make it harder to have SICs, like what they describe about rolling admissions kind of interfering with the ability to have like a meaningful, long conversation that might support SICs better. And then on the other hand, for the facilitator, clinicians describe that leaders who prioritize SICs can play a huge role in getting them the support they need to strengthen their skills, to have like ongoing follow-up support, and really strengthen their confidence in SICs. And so leaders who prioritize really created more of those opportunities for clinicians. And so, yeah, wondering if maybe I saw some comments in the chat, but didn't see exactly what they said. But if these resonate, yeah, feel free to leave any thoughts.
Yeah. Or if they don't, feel
Yeah.
free to add how they don't.
Yes. Mhm. So another factor that came up quite a bit in our findings was the workflow, and documentation was a key structure that came up a lot from clinicians because it influenced the way information was transferred between different clinicians or even settings. When there wasn't a clear documentation process, or if people didn't have knowledge of it, different clinicians might gather different information that all might be helpful for the SIC, but not getting that exchange of information needed really prevented them from having a fulsome understanding of the patient. And so important information can fall through the cracks, especially through during handoffs between clinicians. And then on the other hand, clinicians emphasize that when there were prompts in the EMR or sections in the admission processes that dedicated space or time to input this information, it was really helpful for bringing people and information together, and gathering this information at the outset together also was really helpful.
Great. Yeah. And oh, just going back to that last slide, Grace, just because I want to mention that Eliza, hopefully I'm saying your name right. Yeah, just mentioned about kind of about physician buy-in, which maybe we'll get into in a bit, and also it not being a part of the flow as potentially being a barrier. And so
Mm-hmm.
that's a good part for this part here, where we,
Yeah.
in that workflow piece, we really hear about documentation specifically. So curious if that resonates, Eliza, or if there was something else about that workflow piece. Or no worries to speak at all, or enter more in the chat. But yeah, and Susan mentioned a really good point that we heard a lot directly from participants in British Columbia, and it might look differently, obviously, across Canada in different provinces. But that kind of how our EMRs aren't great at talking to each other necessarily, how many clicks it might get to access documentation from another care setting or another system. Yeah. Yeah. And then, yeah, Alex, that's a great summary of that kind of workflow piece, making sure it's integrated into everyday practice. I like to think of it like hand hygiene, right? Like something that's easy to do. We have sinks everywhere in the hospital, or care settings, and hand sanitizers, that it's accessible, easy, and part of routine practice to do.
Mm-hmm. Yeah, so for interprofessional collaboration, this also came up a lot among the clinicians. And as a barrier, some of the time, the role clarity or role confusion was something that impacted clinicians a lot, whether certain people were already doing certain parts of the conversation, or maybe certain disciplines feeling another discipline needs to go in and have a certain level of information or foundation set up before they then can kind of support that conversation further. Like in the comment here or the quote, there's a lack of clarity about expectations, roles, and responsibilities about SSC as a pharmacist, not a physician. So feeling like there's a bit of limitations in what they can do before they know someone else has maybe set up something beforehand. And for a facilitator, a lot of clinicians spoke to how helpful it was to have informal role modeling and peer support following training to really enforce more practice, get them more comfortable with the conversations, and also see the way successful maybe conversations might look like in practice and being able to have at the elbow support.
Yeah. And just wanted to add as well that I think the interprofessional piece came up a lot in our research, as Grace mentioned. And what's interesting is the Serious Illness Conversation Guide was originally developed by physicians, and it was originally much more physician-centric than it's kind of evolved to, where we have adaptations for different professionals and types of clinicians, as well as the the philosophy has moved a little bit towards thinking about how we can break up the conversation and how different clinicians can have different parts of the conversation. For example, maybe a nurse wouldn't have a long prognosis conversation focused on time, but there's what other ways, as we know, to think about prognosis, and the conversation itself is so much bigger than prognosis that there's ways for every professional to play a bit of a role in the conversation.
Yes, thank you, Laura. And so, kind of one of the final themes we wanted to touch on today was context and society. And so, I think even among clinicians, there's sometimes they brought up the fact that not everyone is comfortable with having these conversations coming from different backgrounds or different comfort levels. And similar to what we spoke about earlier about Joshi et al.'s findings with patients, there's also a varying level of comfort, but also just the fit of the language that maybe the SICG has for different people may not resonate as well. And so that cultural acceptability and making sure it feels safe to kind of talk about these things with the patient and the family and having time to set up that rapport is really important. It was interesting. We had like a rural input as well, and there was a bit of a highlight that rural settings kind of sometimes foster more of like a natural way to have these conversations because sometimes patients will have to leave their home and travel far away to an urban setting to get care. And so it kind of stimulated more of these questions of like, are you sure you want to make the big move over here? Like, what are you willing maybe to trade off for this? And so sometimes that rural relational continuity was highlighted, which we found quite interesting. It was unexpected. Mm-hmm.
Yes. Thanks, Grace. Any of these resonating? I know our overall like anti-death culture in society isn't a barrier that necessarily our toolkit will tackle or be able to um, overturn, but it's just important to think about that there's these broader societal contextual factors going on that are influencing our ability to have these conversations. And regardless, they're helpful to identify, even if we can't
Mm-hmm.
change it.
Yeah, so yeah, feel free to continue reflecting, and if you want to share any comments in the chat, feel free to do so. But these themes kind of led us to the toolkit that we've been mentioning a few times. And so we looked at all these barriers and facilitators, and we wanted to help people be able to select strategies to address them in practice. And so that's why we worked on developing and are piloting an implementation toolkit in the interior of BC. And this toolkit is really focused on kind of facilitating the workflow and the system level contextual factors that we've been speaking a lot about. It's to support clinicians with evidence-based practical support to initiate earlier conversations at a higher frequency with improved quality, and focusing on the workflow and system level because we learned from our research that a supportive context really matters for SICs.
Thanks,
And,
Grace.
mm-hmm.
Okay, so we covered a little bit about earlier about how we have this practice gap we have the training. We know people like the guide. It's a great tool that clinicians like and value, but we're not seeing it sustainably implemented in practice. And so we have that practice gap. And then we found all those barriers and facilitators that we just, some of which we went through, thinking about interprofessional collaboration and documentation and workflows and whatnot. And so what we wanted to do was to build a toolkit, a resources guide approach to support people who champion serious illness conversation work, could be informal or formal leaders who see this work as important and want to work to sustain it in their care setting, to work on closing that gap. So focusing on working ways to develop strategies to address the barriers and facilitators that are preventing your team from having these conversations. And so that's what our toolkit focuses on. So we know that the term toolkit can vary in what it means, but how we decided to approach the idea of a toolkit to help clinicians to bridge the gap from the workflow system change perspective was through an implementation science lens. And so how our toolkit flows is first helping you identify who can support you through program implementation. And then the next part is through understanding the current state. So what do you currently have in place? Do you have mentorship? Do you have training? How do you identify who has these conversations? So some of the questions that we asked earlier in the presentation to get a bit of an assessment and baseline to determine where you're at and what parts of the program you might have and what you might not have. And the idea here isn't necessarily that you do this assessment and you find all these gaps and you have to fix all these gaps, or it shows that you have big problems, but rather it's just kind of to get a lay of the land and think about maybe what are some low-hanging fruit? What are some parts of the programs that might be really feasible to implement? Where are our gaps, but what are our strengths as well? And so it's really meant to be feasible and opportunity to select small, more feasible strategies and opportunities to implement the program rather than implementing the whole thing perfectly, for example. And so then once we've kind of gone through the serious illness conversation program assessment in the second part of the toolkit, then we focused on identifying and prioritizing barriers and facilitators. So some of those that we just went through earlier, of those barriers and facilitators. And in the prioritizing piece is kind of speaks to what I mentioned in terms of maybe choosing some low-hanging fruit. What are some opportunities to address some barriers that we have momentum in our organization for? What are some easy, quick fixes maybe? Sometimes they might exist, sometimes they might not. But really kind of drawing on those strengths and quick win opportunities there. And then based on those barriers and facilitators that you prioritize, kind of thinking about relevant implementation strategies that might work and being able to tailor them to your relevant healthcare setting. And we heard these implementation strategies from champions, clinician champions, so people who want to lead and sustain this SIC work informally or formally within their healthcare setting. We heard from them that we heard a wide range of implementation strategies that were successful from them. And so part of what we've done in this toolkit is list them and offer opportunities to potentially adapt them to your setting and show how that might work. So we want these strategies to be really useful and to be able to be tailored potentially to your setting. And then the last piece is just evaluating and reflecting. And there's been lots of great work in serious illness communication about thinking about how we evaluate, how we look at outcomes and indicators associated with serious illness communication. And so we have a list of some common outcomes in this part of the toolkit and an opportunity to kind of reflect on where you are and where you have to go. So those are kind of the 5 key toolkit component pieces. And in the next part, I'll kind of speak to where we're at and how we piloted and tested them. Thanks, Grace. So once we drafted the serious illness conversation program implementation toolkit, we needed to test it and see if it was usable, feasible, and helpful for clinicians in real time. And so, as I mentioned at the beginning of the presentation, one of our amazing partners at the center is with Interior Health. And so we had the opportunity to pilot our toolkit with them, focusing on a few different care settings within the East Kootenay region, so the Cranbrook area of British Columbia, including home health, long-term care, primary care, and acute care. And so pilot participants were asked for feedback throughout the process, as well as an evaluation survey regarding the toolkit's usefulness, effectiveness, and overall implementation experiences. And we selected the East Kootenay region specifically because they had the presence of strong physician champions. And this was a strength that we really wanted to draw on. And we felt like having the presence of strong champions in a site would really benefit and support the implementation of something like this. And the strong relationships they had amongst the clinicians and leaders and champions of this work within the community. So really an incredible community to work with some really dedicated and wonderful champions who really want to see this work spread. And so we offered drafts of the toolkit to different clinical teams and elicited feedback. I think we had so many great learnings during the pilot process from what we heard from clinicians, but really it kind of gave us the opportunity to look at what we'd done and make some big improvements, especially in thinking about the readability, the usability, and in tweaking around how we were structuring our assessment, our barriers and facilitators, and supporting clinicians in tailoring implementation strategies specifically. And so we are just wrapping up the collecting feedback part of our toolkit. And from there, we're going to go into incorporating all the feedback we got into updating the toolkit to make it better, stronger, more robust. And then from there, the toolkit will be finalized and available for others and hopefully champions to use to be able to implement the conversation in their respective settings. And we're really excited for people to try to use this toolkit, see where it's useful, where it's not, and further opportunities to improve over time. Perfect. Okay. So we could go on longer, but I just wanted to pause there and see if there are any questions overall. At the end of our presentation, at the very end of we also do have a slide where we have our project website, where our toolkit and project updates are being shared, and the future toolkit will be published. And so I will share that at the end as well as my contact information if you have any specific questions about the toolkit or would like to learn more, etc. But just wanted to open it up to see if there's any questions about what we shared so far, or any comments as well. If this resonates or doesn't with you, be happy to hear.
I can't find my hand button.
No worries, you're good. Go for it.
Well done, and it's great that you guys took this on and made it legit, right? Because I mean, all of us that do this work know how great it is. But I'm wondering if you're taking this work to the BC government to lobby them for palliative care funding. Cardiology gets lots of funding, and palliative care does not. And it's going to save the system money in the end, and they're going to get better goal concordant care. So, I mean, I just did a serious illness conversation course in Fernie, and I had three physicians, and I had one administrator, and none of the floor nurses signed up, but their manager would not pay for them to be there. So they're like, well, they got to pay their bills. They've got kids to feed. So I don't blame them, but you know what? If palliative care is a priority, why are we not funding it? So I don't know if you guys have some leverage coming from the BC Centre of Palliative Care and if you guys lobby the provincial government or if that's part of your mandate. I'm just curious.
Well, that's a great question, Susan. Regarding your last question about lobbying, that's not quite as much of a role as the center is to do lobbying for the government, although we can have the opportunity to raise issues and continue to um, advocate and share resources and encourage others and garner more support for palliative care. Um, and we did hear, I echo your sentiment about needing that allocated time for paid time for training for clinicians. And they simply can't really be doing it in the evening off the side of their desk, although some do, but we can't have that as the expectation. And we need it to be incorporated into time. And I believe that actually came up in our toolkit as well as one of the strategies is having that kind of structured paid time for staff. But I recognize, as you mentioned, that requires some more leadership to ensure that we can have that. Um, and then I guess I just wanted to add that another encouraging thing that we're seeing is serious illness conversation training and workshops being integrated into um, the curriculum of professional programs, including medical school and nursing programs. And so while that doesn't address the paid training piece, at least potentially young students and younger professionals might be being exposed to the conversation um, earlier on. And so that might kind of help the training efforts overall, but definitely recognize your concern. Thanks, Susan. Um, and thank you, Alex, for that comment there about funding streams and how that might kind of limit opportunities well. Sometimes they might be focused more for certain professions, such as physicians. And Alex, great to hear that Island Health is trying to make SIC training a part of orientation. That's also great to hear in a really nice way to incorporate those conversations and maybe not have to rely on clinicians to take the training on their own time or ask managers to have that paid time, which we know is quite rare, especially given health authority cuts right now. Exactly. Any other questions, thoughts? Thanks so much, Susan, for that comment. And I echo your sentiment about wanting to lobby and garner more momentum for the overall palliative approach too.
Yeah, I think we just need to just let that voice be heard, that palliative voice be heard, because people don't know about it. Like I did a session here for the community, and they didn't even know that they could have a home death. Like, I mean, that's been part of our practice for a long time. And it's interesting. I think a big problem with moving things forward is lack of communication between different sectors. And, when I say lobby, maybe that's a strong word. Maybe it's having a conversation with the government or whoever it is in power to say, hey, this is our experience. This is what we're seeing. We think this is valuable. And just planting the seed. And the more we plant those seeds, maybe the closer we'll come to some of these objectives. But I feel like we're still a little part of the healthcare system. And yeah, it's lots of people don't understand palliative approach. They think it's end of life, and they really think there's not much to it. So, yeah, great work, and you guys are planting the seeds. So, I'm just encouraging you to take it to higher level if you have the opportunity. So, thank you.
Thank you, Susan. Thanks. Great. Okay, well, we can just go to the next slide here so we have a chance to scan our QR code if you want, or write down my email address. Happy to take questions, or just visit our BC Centre for Palliative Care broader webpage. It's totally fine. But yeah, I know that it's 12:49. Happy for folks to get 10 minutes back or to stay longer and ask questions. Totally up to you, but I wanted to offer the opportunity to close here and wanted to thank everyone so much for attending, listening, sharing your thoughts, comments, insights. We're really looking forward to sharing the toolkit, hearing more from you, from people like you about it, if it's useful and how or how not. And yeah, thank you so much for your time on this later December busy time of year, Wednesday afternoon. Really appreciate it. Thank you.